Hey everyone, today we're covering the ICD-10-CM updates for 2026. Now, my goal is to make the changes kind of practical. So, what's new? What guideline tweaks are we going to see? What do they mean? And how we can apply those in our daily coding. So, I'm going to point out where documentation tends to trip people up and share how it applies in your daily coding without getting too far into all of the changes that aren't really going to impact your daily workflow. If you're new here, hey, I'm Victoria. I'm a medical coder, auditor, educator, and content creator. And on my channel, I provide tips, tricks, and tutorials to help you be successful in a medical coding career. If you haven't already, I encourage you to subscribe, hit the notification bell, and do all of the YouTube-y things. But without further ado, let's get into these code changes. Now, a quick disclaimer, this session is educational and it summarizes the official materials, but it's not a substitute for the source document. So always verify against the current ICD-10-CM guidelines, the tabular list, and any payer or facility policies you may know. And when in doubt, validate in the code set and query the provider for clarity. Use these notes as a teaching companion and always keep your compliance hat on. So what are we seeing this year as far as changes? It's a pretty decent wave, 487 new codes. And I know that sounds scary, but a lot of them are because there's 10 different 7th character extension variations of it. So some of these times we have these big numbers and they're not as intimidating as they initially seem. The key is really understanding why these codes are added or revised and how we're going to use them, for making sure that we have clinical accuracy, what needs to be in the documentation. We have 38 that were revised. Again, some of these were just a comma was added. There were some narrative changes. I'm not going to go over that. I'm going to go over more so the code descriptions and 28 codes that were deleted. Most of those deletions were based off of codes that are now expanded, so we're getting rid of the less specified codes. Starting with guideline changes. I always like to start with the guideline changes because they are kind of the backbone of making sure that we have accurate sequencing in coding. This year includes clarifications. Some of them might be small. Some of them have some big impact. Some of them are whole new sections. And then things like how to handle multiple sites, how to treat sequencing, even seasoned coders, I think, benefit from going over the guidelines every single year. Starting with in 1A7 for punctuation, there's a clarification here on commas. Now, in the alphabetic index, punctuation matters sometimes more than we think. A comma might not just be a pause. It could be a signal that we need alternate wording. It could be required like an optional modifier, or act like the end or, and misreading punctuation can send you to the wrong code. So this one is just a reminder about not just skimming things and making sure that we are reading very carefully when we're looking at this different verbiage in the index. Another key clarification is the definition of multiple sites. The classification defines multiple sites as 2 or more sites. That means if you have documentation for each specific site, you code them individually. You only use the multiple sites code when the provider doesn't specify. And this applies across chapters unless otherwise noted. So think if it's a documented site, we code each site. If it is unspecified multiple sites, then we use the multiple sites. HIV sequencing saw some updates this year. So what this guideline update says is that if AIDS or HIV disease is documented or the patient is treated for an HIV-related illness, we assign B20. If the patient is HIV positive with no documented symptoms, we use Z21. If it is inconclusive HIV serology, that's R75. New versus prior diagnosis doesn't change sequencing rules. We follow the reason for encounter logic. Once a patient has ever had HIV-related illness, they remain B20 on all subsequent encounters. It is never reverted back to Z21 per our coding guidelines. If it is a pregnant patient, pregnancy, childbirth, puerperium, we start with 098.7. That is HIV complicating pregnancy. And then we add B20 if they're symptomatic or Z21 if they are asymptomatic. Remember, Chapter 15 codes always take sequencing priority. When we are having encounters for testing, so maybe the patient is just getting screened for HIV. Z11.4 is for our screening when they are asymptomatic. If the symptoms are present, we code the signs and symptoms instead. Z71.7 is used when counseling is provided, including if it is a negative result and we are doing a follow-up to inform the patient about that negative result. So this is all about matching the code to the reason for the visit and the outcome. C1A2, selection of sequencing of HIV codes. Section K here is brand new, but it was not bolded in the guidelines. So that was something that I kind of caught as I was reading through them. I'm like, this whole section here looks new, but they forgot to bold it. And I checked back on the April updates and it wasn't added then. So I think they just mistakenly forgot to bold this whole section that was new, because there were other brand new sections that they did in fact entirely bold. So I don't know what happened with this one. You might get your print ICD-10-CM book and it'll be bolded because the publisher may have caught it and updated that. But in the CDC guidelines and stuff that we have available online, it wasn't bolded. But in this guideline, what we're looking for is things like the medication status. So HIV disease or related illnesses on antiretrovirals, B20. HIV positive, asymptomatic on antiretrovirals, Z21 category, unless there's documentation of HIV disease. If it is for PrEP, if it's the pre-exposure prophylaxis, we actually use code Z29.81, and that's for encounters to administer PrEP. And any documented risk factors that that patient has include those as well. We see some revisions this year to our guidelines regarding the sequencing of our patients that are receiving radiation therapy, chemotherapy, and immunotherapy in relation to treatment of a neoplasm. When the chief reason for the encounter is the administration of anti-neoplastic therapy, we sequence the appropriate code from Z51, Z51.0 for radiation therapy, Z51.11 for chemotherapy, Z5112 for immunotherapy. And the malignancy being treated is coded as a secondary diagnosis. The exception for this is if it's for insertion or implantation of radioactive elements, so brachytherapy, the malignancy is principal and Z51.0 is not assigned. Brand new this year and kind of a big buzz is this new code E11.A, and that is type 2 diabetes in remission. This came out of the committee discussions because they said that the phrase resolved is sometimes used in notes, but it's not the same as remission. So if the provider documents remission, you assign E11.A. If it just says resolve, I would query the provider for clarification. The reasoning was to support the accurate long-term tracking, since remission doesn't really erase the risk of recurrence. And this helps clinicians and payers and researchers distinguish between who has active disease and who is a patient who maybe has achieved control of their diabetes. Hypertension rules got tightened up. When hypertension is documented with certain heart conditions like heart failure, myocarditis, unspecified heart disease, you assign a code from category I11, hypertensive heart disease, with additional codes that specify the type of heart condition. But if the provider says the heart condition is not related to the hypertension, we code them separately. But this update helps coders rely more on the documentation rather than just assuming. And what it also does is it outlines the specific conditions that need to be related in order to assign the I11 code. Now let's get into some of the changes to the codes themselves. Starting with chapter 1, I'm going to go through chapter by chapter. I know in the past I've kind of done by specialty, but for this one, I'm going to go chapter by chapter. Chapter 1 picks up a few just very targeted additions. We have some expanded HIV guidelines that we already covered, but each year infectious disease codes evolve alongside the various public health concerns that we're having. Keep in mind, these changes are often driven by the need to track different emerging treatments or different outbreaks they're having. So for this one, we're seeing an infestation by Demodex mites, and our BA8.09 code is added as well. A couple of new codes in our Neoplasm section. So cancer coding tends to change when it's a focus on like a new therapy approach, or we're aligning better with the tumor classifications. And this year doesn't, overhaul the entire structure. We just saw a few updates to reflect some of the committee decisions about improving specificity for research and for registry purposes. So we now have some different codes for malignant inflammatory neoplasm of the breast, and of course, laterality, right, left, and unspecified. Chapter 3, one theme this year was abnormal lab findings tied to conditions like autoimmune disorders. So, for example, new codes capture abnormal rheumatoid factor or anti-CCP antibodies without clinical RA. The committee emphasized that these patients may not yet have arthritis, but their labs put them at a higher risk. So we see here some of the additional codes now in our category D71 to support that, so that they can have that information for preventative studies, for clinical trials, for therapies, and things that might look to aim to delay the onset of RA. Besides diabetes in remission, which we already kind of talked about, Chapter 4 saw additions linking the evolving metabolic research that we've been seeing. So some of the updates here include hyperokesiluria, which refers to excessive oxalate in the urine. Oxalate is a natural chemical found in many foods, and the body produces it as a waste product. So normally small amounts leave the body through urine, but in this condition, they have much higher levels that can lead to kidney stones, kidney damage, or even systemic issues if it builds up too much in the tissues. So we have two different forms: primary, secondary. And primary is a rare genetic disorder where the liver doesn't make enough of the enzyme that prevents the overproduction. Secondary can result from dietary factors, like if you have a very high intake of oxalate-rich foods or vitamin C, or intestinal malabsorption or other underlying conditions. We also see it specified from dietary, enteric, and then other secondary. The ICD-10-CM Coordination and Maintenance Committee noted that having a more specific code for this is going to help them better track their patients in their clinical care, in their research, and kind of distinguish it from more general metabolic disturbances and help them target some new therapies. There's new codes for familiar hypercholesterolemia, which is a genetic condition that causes very high cholesterol from birth. The update now sets homozygous FH and more severe form inherited from parents from heterozygous FH, where only one parent passes down the gene. There is also an unspecified option for coders. The big takeaway here is to look at the provider's documentation and try to find that specificity now, that because we have that distinction, and that distinction does matter for code assignment. We also have a new group of codes under E83.82, disorders of pyrophosphate metabolism. And that helps regulate calcium in the body. And when metabolism breaks down, calcium can build up in the blood vessels in the skin or the bones. And this new, more detailed code allows coders to capture rare genetic conditions, such as arterial classification of infancy, ENPP1 deficiency, ABCC6 deficiency, and CD73 deficiency. Each of these conditions can look different in patients, ranging from calcified arteries, which would be more so seen in infants, to connective tissue disorders. And the reasoning behind those changes is because previously patients with these rare conditions were really lumped into one big, vague category of other metabolic disorder. So now we have more specified codes that we can have our providers document and then code out so we can have better clinical reporting of those conditions. Here we see new codes for lipodystrophy, which is a group of conditions where the body loses fat tissue in certain areas or throughout the body. The loss of fat isn't just like, oh, cosmetically, I wanted to lose fat. It can cause problems with metabolism, insulin resistance, and lipid abnormalities. And in the past, coders only had like a general lipodystrophy code, but now we can assign codes that tell a more complete story. So the updates break down lipodystrophy into types. So we have partial, generalized, localized, HIV associated, and then other not otherwise classified, as well as, of course, our unspecified code. So if the providers continue to document just lipodystrophy, there is still an unspecified code to utilize. No changes for our Chapter 5 codes. In Chapter 6, Diseases of the Nervous System, there is a lot more detail now for relapsing, readmitting multiple sclerosis and secondary progressive multiple sclerosis types. Each of those has options for active versus a non-active status. And this was prompted because there are different treatments and prognoses depending on the subtype. So providers really wanted to have codes that captured that exact form so that providers have full descriptions and they can better manage a patient's MS. We also see the addition of primary apraxia of speech, which is a rare disorder where patients gradually lose the ability to coordinate speech movements, even though muscle remains strong. Including this condition separately makes it easier to track in neurology and speech therapy data. And finally, under muscular dystrophies, there is a new code for limb girdle muscular dystrophy due to gluten-related protein dysfunction, and that's G7 1.036. And this is a specific genetic form of muscular dystrophy that was previously lumped under some more, broader categories. We have a brand new category for other specified inflammation of the eyelid. Before, inflammation of the eyelid was in broader categories, but ICD-10-CM now carves out this specific section. What's different is that coders can now assign a code that not only says other specified inflammation, but also identifies the eyelid as upper, lower, both, or unspecified, and whether it's right or left. So we're looking for a lot of anatomical locations here. So very carefully dissecting the documentation here. There's new detail for two conditions, thyroid orbitopathy and neurovascular secondary angle closure glaucoma. Thyroid orbitopathy, sometimes called thyroid eye disease, happens when thyroid disorders, most often Graves' disease, causes inflammation and swelling around the eye. The new codes let us specify whether it's in the right eye, left eye, both. Of course, we see that a lot. And anything that has to do with the eyes, is it the right or the left eye? So making sure that we have the appropriate documentation from the providers that specifies thyroid orbitopathy when they have that. Neurovascular secondary angle closure glaucoma is a severe form of glaucoma caused by new abnormal blood vessels that block fluid drainage in the eye. And again, codes are broken down by right eye, left eye, bilateral, etc. The new codes here relate to Fontan circulation. The Fontan procedure is a type of heart surgery used in children that are born with complex congenital heart disease, often when only one ventricle is functional. The surgery reroutes blood flow directly into the lungs, which bypasses the heart's right ventricle. And while this helps patients survive into adulthood, it creates unique long-term complications known as Fontan-associated conditions. We see here the codes that they've added are for liver disease, lymphatic dysfunction, because those are the most common ones. And then we also have other associated conditions and an unspecified related condition. Chapter 10, no new changes. Chapter 11, no new changes. Chapter 12 is seeing a bunch of new codes for non-pressure chronic ulcers of the areas of the abdomen, chest, neck, face, groin, upper arms, and forearms. In the past, ICD-10-CM has focused heavily on pressure ulcers and diabetic ulcers, but we lacked a lot of really good options for chronic ulcers in other body areas. Each of these codes requires a sixth character to describe the severity. One is limited to breakdown of the skin to, or 9 is other unspecified, but to 6, I guess, which would be with bone involvement without evidence of necrosis. So we do need specificity in the documentation to assign the correct 7th character for the severity of that ulcer. A small revision was made to the codes for abscesses and furuncle on the backs to now specify that it includes the back, the flank. Chapter 13, one new code, M05.A, abnormal rheumatoid factor and anti-citrulline protein antibody, so anti-CCP without rheumatoid arthritis. So in plain terms, it applies to patients who test positive for these antibodies but don't yet meet the criteria for rheumatoid arthritis. Research shows that these antibodies often appear years before symptoms, so they are an indicator that the patient is at high risk of developing RA in the future. Few minor Chapter 13 revisions. M21.15 now specifies that it says unspecified hip rather than just unspecified. M24.076, a little S was added. And M61.129 now specifies that it is upper arm and not just unspecified arm. We have new codes for immune complex membranoproliferative glomerulonephritis and APOL1 medicated kidney disease. IC-MPGN is a rare kidney disease where the immune system deposits complexes in the kidneys, causing inflammation and damage. The ICD-10-CM now separates these cases into acute nephric syndrome and nephrotic syndrome. Each of these is further broken down into the different categories of idiopathic. Is it secondary or is it, unspecified? So the other important addition is N07.5 for hereditary nephropathy with APOL1 medicated kidney disease. And that's a genetic variant that raises the risk of kidney disease, particularly in people of African ancestry. And the committee minutes emphasized that this code was needed so that AKMD could be tracked separately in data and research instead of being buried under nonspecific hereditary nephropathy codes. Chapter 15, there were no new codes to pregnancy, childbirth, and the prepubertal. However, we did see one small revision on P09.6. So previously, the code description was abnormal findings on neonatal screening for neonatal hearing loss, and it's now simplified to abnormal findings on neonatal hearing screening. The change removes the assumption that the abnormal screen automatically kind of means hearing loss. And as the committee pointed out, a failed newborn hearing screening doesn't always equal a diagnosis. Sometimes it's just due to fluid in the ear or a testing issue, and they might just need to do a follow-up after that issue has resolved, and then that will show that they have normal hearing. So updating the wording here kind of prevents coders from assigning a code that could imply a confirmed diagnosis of hearing loss too early. There's new codes for several rare congenital syndromes in Chapter 17 and expansions on how we capture Usher syndrome. So codes now exist for, and I apologize if I'm pronouncing this correctly, Howe Foundation syndrome, CTNNB1 syndrome, and Kabuki syndrome. And these are rare genetic conditions that often involve developmental delays and multiple organ system involvement. The committee supported their inclusion so that they aren't hidden, again, under these like vague congenital malformation kind of categories. So we wanted something more specific. The update also gives us new detail for Usher syndrome, which is a genetic condition that causes both hearing and progressive vision loss. So we now have that, and we have type 1, type 2, and type 3, which of course is going to be driven by provider documentation as far as what type that patient has. Like the previous slide, these are conditions caused by pathogenic variants in specific genes that affect the brain and the nervous system development. So ICD-10-CM gives us codes tied directly to the type of gene involved. So QA 0.0109 and QA 0.011 through 12 cover neurodevelopmental disorders that are linked to ion channel genes, glutamate receptor genes, and other receptor genes. QA 0.0131 is for SLC6A1 related disorder, which is a rare genetic condition associated with epilepsy, developmental delay, and autism spectrum features. And QA 0.0139 is what will allow coders to capture disorders linked to pathogenic variants in other transporter or solute carrier genes, again, reflecting the fact that these conditions are being diagnosed more often with all of the new modern genetic testing that we have. These Chapter 17 conditions are tied to mutations in very specific genes that affect brain development, learning, and behavior. So ICD-10-CM has new codes for syntaxin binding protein 1 related disorder, which is linked to epilepsy and developmental delay, as well as DLG4 related synaptopathy, which impacts synapses or the way the brain cells communicate, often presenting with intellectual disabilities and seizures. We have FOXG1 syndrome, which is a rare disorder that causes severe developmental delays and structural brain abnormalities. And then we have some broader categories for other disorders tied to the genes, such as the 0159, which is kind of like more of an unspecified kind of code. And then our QA 0.8, which is our other specified disorders. Just a few minor Chapter 19 revisions. We added the word type to craniosynostosis, and then there was a comma added to one of the other codes for Q75.02. Chapter 18, there are several new codes to describe different types of pain in the abdomen, pelvis, and flank, as well as tenderness in these areas. So pain and tenderness. So we have those broken down between pelvis, suprapubic, abdominal pain, flank tenderness. Flank pain is broken down by the side. So is it an unspecified right flank pain, left flank pain, bilateral flank pain, before we only had kind of the generalized codes? We also see a new code this year for R11.16, which is cannabis hyperemesis syndrome. And this is a condition seen in heavy cannabis users who develop recurring episodes of severe nausea and vomiting. And the committee added it after feedback that it was being documented, but really didn't have a properly designated code that tied, I guess, kind of the hyperemesis to the cannabis use. Costovertebral angle tenderness is also new. This is an important finding, often documented in workups for kidney infections. So coders can now report it as right-left bilateral unspecified. And then we have R76.81 captures abnormal lab findings. So patients who have abnormal rheumatoid factor or anti-CCP antibodies without rheumatoid arthritis, and R76.89 gives a place for other abnormal immunological findings in serum that don't fit. We have specific codes for contusions, or what we more commonly would refer to probably as a bruise, of the abdominal wall, the groin, and the flank. Again, we saw kind of this separation of all of these different things related to like flank. We're breaking down the types of injuries you can have to the flank: abrasions, blisters, external constrictions, superficial foreign body, insect bites, and other bites. And there's a new code for, just the unspecified superficial injury of the flank. These changes were made to reflect how providers actually document these minor injuries. We have specific codes for contusions, or what we more commonly would refer to probably as a bruise, of the abdominal wall, the groin, and the flank. Again, we saw kind of this separation of all of these different things related to like flank. We're breaking down the types of injuries you can have to the flank: abrasions, blisters, external constrictions, superficial foreign body, insect bites, and other bites. These changes were made to reflect how providers actually document these minor injuries in the ER or the urgent care setting, and make sure that we're capturing appropriately as well. Open wounds and lacerations of the abdominal wall, specifically. Again, the flank have new codes. So, more detail as far as, was it an unspecified wound? Was it a laceration with or without foreign body? Was there penetration into the peritoneal cavity? Puncture wounds are included in that breakdown that we have for flank as well. Open bites, unspecified wounds of the abdominal wall, left, right flank, with or without penetration into the peritoneal cavity, puncture wounds of abdominal wall. And then after we get all of the new codes related to the flank and the abdomen, we have new codes adding poisoning, adverse effects, and toxic exposures related to two substances: fluoroquinolone and xylazine is a veterinary sedative that has been increasingly detected in illicit drug overdoses. And we now have the toxic effect codes for that. So was it accidental, intentional self-harm, assault, or undetermined? We are adding new codes that expand how we capture war-related conditions and food-related anaphylaxis and adverse reactions. So T75.830 for Gulf War illness, and T75.838 for effects of other war theater are new additions. These codes were created to capture conditions that are linked to military service in specific conflict zones, and they were added because veterans often present with chronic multiple symptom illnesses, and having specific codes really helps benefit their research and their benefits eligibility and have a lot more accurate reporting of that. The rest of the codes added relate to different food-induced anaphylaxis and adverse reactions. What we're seeing right now is a lot of things related to baked milk and baked egg. I guess kind of breaking down like the raw egg versus the baked egg. And this slide just kind of continues that, more detail for the milk and egg products. So kind of distinguishing that these specifically is tied to baked egg or baked milk. And then we also have T78.19X, which is kind of the catch-all for any other adverse food reactions that are not otherwise classified. Previously, the descriptions for these Chapter 19 codes included both the wrist and hand together, but now the wording has been updated, so these codes that we see this revision for this year only apply to the hand. There was also a typo. So this is supposed to say thigh and not high, and it was just a minor typo there. Getting closer to the end, our Chapter 20 codes for external causes of morbidity. We have some additions for very specific injury scenarios and activities. So W44.H9X is other sharp objects entering into or through a natural orifice. And this captures situations where a foreign object like a pin or a piece of glass accidentally enter through the mouth, the ear, or the nose. W45.3XX is for fishing hook entering through the skin. And that's because there's a lot of fishing related injuries, but we want to specifically capture when it's like a hook piercing versus like they fell off of the fishing boat. We've seen some codes added for overpressure and low pressure, high pressure level blasts in war and military operations. Some additions for splitting wood And then other outdoor activities was added, more of the catch-all category. Several new codes expanded the genetic susceptibility category. So, do you have genetic susceptibility to fallopian tube cancer, colorectal cancer, or other digestive systems, urinary tract cancer, kidney disease, etc.? And these codes are used when genetic testing or family history indicate the increased risk, even if the patient doesn't have that disease. We added some new encounter codes as well for prophylactic surgery. So, prophylactic oophorectomy for patients without known genetic or familial risk factors, and prophylactic salpingectomy for patients without known or genetic familiar risk factors. And then J40.89 is for our encounter with other prophylactic surgery. The social determinants of health codes have added some new additions to report financial insecurity. And these allow us to capture when patients struggle with basic needs like paying for their utilities, or when there is other specified or unspecified financial hardship. These codes reflect the growing recognition that financial strain is something that very directly impacts a patient's health as well as their access to care. We have some new exposure codes that cover contact with and suspected exposure to Gulf War theaters and other war theaters. And the purpose of these is to document patients who may have been exposed to environmental or chemical risks due to their military service, even if they might not yet have an official diagnosis. We have some new family history codes. These expand the family history codes for reporting fallopian tube cancer, APOL1 medicated kidney disease, and other kidney and ureter disorders. And then there's some new Z codes that expand the family history, personal history, allergy reporting, and exposure risk. Like we talked about that baked egg and the baked milk earlier. So now we have some Z codes that designate the allergy status for those as well. And then just some family and personal history related to things like fallopian tubes, malignant neoplasms, and neoplasms in situ of those areas. And lastly, we have a few minor spelling and grammatical corrections in chapter 21. Just a couple of like really just minor stuff there that was changed. And then chapter 22, codes for special purposes, didn't have anything added to it this year, which I guess is kind of good because otherwise that would mean that we'd have some kind of new disease that we urgently needed to start reporting. ICD-10-CM keeps evolving to capture the reality of all of the different patient care needs that we have these days. And our coder role is kind of to connect the dots between that documentation and these new levels of specificity that we're seeing between now and whenever maybe one day possibly we're going to get into ICD-11. So, we're seeing more specificity everywhere, even as far as locations. We saw those breakdowns of the flank from right and left. Social determinants of health are expanding, and keep an eye out for documentation. Make sure the providers are documenting the location, the laterality, the severity, the genetic and family details, because that impacts the patient risk factors as well. I hope you found this video helpful. If you did, don't forget to like, share, and subscribe. I will see you guys in the next video. And until then, just keep on coding on.